Tone, warm, calm, and reassuring. Welcome back, everyone. Today, we are stepping into the neonatal care unit or NICU to take a close look at one of the yet critical procedures performed for our tiniest, the placement and securing of an enteral feed for newborns who are premature, critically, or simply too weak to coordinate the complex reflex, swallowing, and breathe. These small tubes are an absolute life. They ensure the infant receives vital nutrition or medication directly into their stomach without expending pressure. As clinicians or caregivers, performing this procedure requires a delicate balance of strict adherence to safety protocols, and a profound commitment to infant. Let's break down the step-by-step process of how we approach this safely. Tube is lubricated and gently advanced. Either the nose and nasogastric tube or the mouth and orogastric tubes are frequently preferred for very small because they are obligatory nasal, and we want to keep their airways as clear as the tube is advanced to the prim measure. The provider monitors the infant's vital signs and cues. We look for any signs of respiratory coughing or color change, which would indicate the tube has accidentally entered. If that occurs, the tube is withdrawn immediately. Once the mark is reached at the lip, the tube must be verified before anything is in. The gold standard for verification is checking the pH, aspirated gastric content, using pH indicator strip. A pH of 5 or less generally indicates correct gastric. In some high-risk scenarios, an X-ray may be ordered to definitively confirm. After verification, securing the tube is a fine art, especially when premature, is incredible. Providers use specialized hydrocolloid barriers directly on, then apply the adhesive tape over the. This stabilizes the tube securely while protecting infant skin from tearing or breaking. During future removal,